Hello, Dr. Poole and research classmates. I'm Stephanie Merritt. I'm a registered nurse and current FNP student at South College. This course has led me to research in the area of rural pediatric obesity. My presentation is titled Telemedicine, Bridging the Healthcare Gap in Rural Obese Children. I hope you find this presentation informational and engaging. Public health in the rural United States is underfunded, and it puts children at a greater risk of chronic disease, leading to increased mortality risk. Rural areas isolate children from accessing health care, while the urban-rural disparity gap continues to widen. More research is needed to identify effective solutions that will expand programs to treat pediatric obesity in rural communities. The purpose of this presentation is to examine the impact telemedicine could achieve as a strategy to close the disparity gap for rural obese children. 7.5 million children live in the rural United States. Increasing their access to health care should be a top priority for researchers and policymakers. Children in rural communities have a 20% prevalence of obesity, which is significantly higher than urban children. Childhood obesity increases the risk of adult chronic health issues such as hypertension, asthma, mobility problems, and heart disease. Psychosocial aspects of pediatric obesity are low self-esteem, social shaming, eating disorders, depression, and suicide. Healthcare costs in the U.S. are skyrocketing, and obesity accounts for 32% of the total economic burden on the healthcare system. These statistics also include a disproportionate number of obese patients who have diabetes, heart disease, and cancer. Decreased quality of life is correlated with obesity due to the impact of economic, physical, social, and mental factors. Obesity is the 5th leading cause of death worldwide. Obesity treatment has been proven to be more effective at younger ages, the preschool years, think ages 2 to 3 years old. But children living in rural areas face challenging barriers to treatment. We know that obese children are more likely to turn into obese adults with early mortality rates, and this is why treatment in the younger years is so important. These numbers shown here reinforce the need for research and policy changes. My PICO question is, in rural obese children aged 2 to 19, how does telemedicine compared to treatment as usual affect weight outcomes within 6 months? For this study, an intervention group, which is the telemedicine group, will be compared to a control group, which is treatment as usual. I'm going to tell you my definitions. These are specific to my presentation. Telemedicine is defined as technology used by a clinician to provide medical services at a distance and may be telephonic or audio-video. Treatment as usual is defined as face-to-face office visits only. Inclusion criteria are children between the ages of 2 and 19. They must live in an identified rural area. Rural areas are identified by a population density less than 500 persons per square mile and have a BMI greater than 95% for their age and sex. Primary outcome is BMI, and secondary outcome is minutes of physical activity per day. Measures will be assessed at baseline, 3 months, which is the halfway point, and again at 6 months, which is post-treatment. This slide depicts the search strategy and results as I began my research. Databases searched were Ovid, Medline Complete, PubMed, and Google Scholar. Google Scholar was eliminated from the search due to the high number, 17,000 to be specific, of search results. Limiters and exclusions only brought that number down to 12,000, so Google Scholar was nixed. Using a combination of the remaining databases, I used the keywords pediatric, obesity, rural, telehealth, telemedicine, and treatment. Mesh terms that were helpful were health promotion, diet, exercise, and health behavior. I narrowed my databases to Medline and PubMed. Added limiters were English language, studies from the United States only, full text, peer-reviewed, and articles published after January 1st, 2017 until now. PubMed allowed me to further filter the results to clinical trials and systematic reviews only. Inclusion criteria were pediatric population aged 2 to 19, rural U.S. settings, children with a BMI greater than 95% for their age and sex, and the study designs of randomized controlled trials and systematic reviews. Exclusion criteria were infants under 2 years old and adults older than 19. All studies not conducted in the United States and low-level studies such as opinion pieces. All of those were excluded. A total of 2,112 studies were found. 518 studies were duplicates and they were removed. Automation tools removed 497 studies, and this left 21 studies that I screened, of which 6 were excluded for various reasons. The total number of studies retrieved and assessed were 15. I included 11 of those in the review. Childhood obesity is a public health issue that can have lasting effects into adulthood, which include risk for early mortality. Compared with children in urban communities, rural children have a disproportionate prevalence of obesity. The literature is clear. Rural children face multiple barriers to healthcare access. Rural populations are underrepresented in research, which highlights rural health disparities and the need for future research to facilitate this population into clinical trials. Current data reports risk factors associated with pediatric obesity are genetics, environmental factors, and cultural norms. Poor family health, food security, and low income are also associated with pediatric obesity. These factors indicate a need for a multifaceted treatment approach. Researchers need to develop comprehensive treatments to address all risk factors. The description of the setting for this presentation, for this research study, is very simple. Childhood home in rural areas, the family home for the children in the rural areas, rural community schools, and rural primary care offices that pediatric patients are treated at. This slide represents the change model that will be used to implement the evidence-based practice. This is the proposed plan change process using the Advancing Research and Clinical Practice through Close Collaboration model. It's called the ARC model, and again, this is a change model that I can use to implement my evidence-based practice. The first is I'm going to identify my stakeholders. Stakeholders for the proposed evidence-based practice change are primary care providers in rural settings, rural community schools, the school staff, who are the school nurses, guidance counselors, teachers, county health departments, parents, and the pediatric patients themselves. Next, you want to assess culture and organizational readiness for implementation into the healthcare system. I would do that through questionnaires. The questionnaires will be sent home from the school with identified children who meet the study criteria. One questionnaire will be geared toward the parents and one will be geared toward the children. I'll also send out questionnaires and emails that will be sent out to primary care providers, school and health department staff. The questionnaires will ask for feedback to identify meaningful indicators for the proposed implementation of telehealth. So next in the change process, you identify the facilitators and barriers of the evidence-based practice process in the organization. For me, barriers to the plan change may be no internet access, knowledge deficits in the use of technology, rejection to change or lack of willingness to adopt the program. And facilitators that help mitigate barriers for this specific problem may be using telehealth technology at school if internet is not available at home, teaching families to use telehealth to ensure their confidence in using the technology, and intentional interviewing and counseling to help promote adoption of the new change. A team approach to care is going to be needed from community providers. Next, identification of the evidence-based mentors. Evidence-based mentors are primary care providers and nurses employed by the health department and school system. Physicians, mid-level practitioners, and registered nurses are all qualified to be mentors. Next, implementation of the evidence into the organization or the practice. During implementation, telehealth devices will be placed in rural family homes and within community schools where the school nurse will oversee that technology. And finally, evaluation of the outcomes resulting from the practice change. For me and my study, that will be evaluation of outcomes will be conducted at 3 months, that'll be the halfway point through the study, and at 6 months, which is post-treatment. Both the intervention and control groups will be evaluated. So I had a plan for implementation. I also need a plan for evaluation. Evaluation questions are needed to help guide the process as well as collect results. For example, at 3 months, a question may be, would a 24-hour dietary recall be helpful to determine eating habits? Indicator performance measures are markers of accomplishment or progress. They could be measured to show that progress is being made. For this study, the BMI and the number of activities minutes per day are measured. Data is collected by measuring the children at baseline, 3 months, and 6 months. Data is also collected from the accelerometers at 3 and 6 months. Criteria for evaluation are a moderate to significant change in BMI and significant changes in minutes of activity per day and sedentary lifestyle. For this research, data collection and analysis, statistical analysis will be used. Quantitative data is collected using a pre and post design. The mean change in BMI and activity minutes per day are recorded for the treatment group and then for the control group. Results compared between the two groups will be conducted post-treatment, and those will also have a statistical analysis. They are also considered quantitative data. In conclusion, technology has shown great promise in closing the gap of healthcare disparities associated with geographical access to healthcare. Telehealth has become an integral part of our medical infrastructure and a critical means of providing care to those in rural areas. Given the high incidence of rural pediatric obesity, which contributes to negative physical, social, and psychological well-being, more research on this issue is critical. Literature supports the implementation of telemedicine as a strategy for overcoming barriers facing rural clinicians and families in finding effective pediatric obesity treatments. I hope you enjoyed this presentation and that you learned something valuable. Thank you so much for watching.